Good afternoon, everyone. Myself, Dr. Gautam, Senior Resident DM, Critical Care Medicine from AIIMS Bhopal. The topic of discussion today is clinical features and emergency management of organophosphorus poisoning. So the flow of my talk will be what is the current statistics of organophosphorus poisoning in India, what is the mechanism of action of organophosphorus poisoning and how it manifests, what are the types of organophosphorus compounds, why it is important to know what compound it is and how it is important to prognosticate and how it decides the mortality of the patient, what are the clinical manifestations, and what is the emergency management which we are supposed to do on timely basis in the emergency department. So coming to the current stats, we are all aware throughout the world, Asia ranks top among the usage of pesticides, contributing around 50 to 60% of pesticide usage in the world. In India, Maharashtra and Uttar Pradesh is using pesticide on a very large scale. The pesticide consumption by the farmers is on a very large scale compared to all the other southern and eastern northern states. Though the consumption of organophosphate is predominant by the Uttar Pradesh and Maharashtra, the predominant cases are seen in Tamil Nadu, Kerala and Karnataka. So among all the pesticides, including fungicides, bactericides, herbicides, weed killers, insecticides ranks top in human poisoning. So this is the statistical analysis of all the states showing human poisoning cases with organophosphorus, where this is the status of 2022, where Kerala ranks first, followed by Tamil Nadu and Karnataka. So coming to the common classification of pesticides based on the chemical composition and target organism, it is divided into organochlorine, organophosphate and pyrethroids. These are the three most common compounds which we face in the emergency department. And based on the target organism, it can be divided into herbicide, insecticides, fungicides, bactericides and rodenticides. So today the topic of discussion is insecticide. So this is a list of organophosphorus compounds which are commonly used compounds of parathion, chlorpyrifos, diazinon. Here in AIIMS Bhopal, we get cases of chlorpyrifos and parathion on a common basis. Uncommon organophosphorus compounds are phosphate, phenyltriothione and tetrachlorphenphos. So this is the WHO classification of organophosphorus compounds based on its toxicity, classified into highly toxic, moderately toxic and mildly toxic, among which the commonest compound parathion comes under highly toxic, followed by chlorpyrifos, which is moderately toxic. So we usually get only these cases, highly toxic and moderately toxic, and the mildly toxic compounds are usually used in the household repellents, insecticide repellents. So coming to the physiology of neuromuscular junction, to understand how organophosphate poisoning acts, so we should understand how this works. When the action potential reaches the presynaptic neuron, the calcium channels open and the calcium starts getting influxed. The calcium opens the synaptic vesicles and all the acetylcholine from the synaptic vesicles gets released through the process of exocytosis. It reaches the synaptic cleft, starts binding on the acetylcholinesterase receptor on the postsynaptic neuron. Once it sits on the acetylcholinesterase enzyme, it starts opening up the sodium channels and the sodium influx starts leading to the depolarization of the muscle. So the muscle action potential manifests there and that leads to the muscle contraction. So this is the normal mechanism of how acetylcholine is being synthesized, stored, released, and it causes muscle contraction. So before knowing how OP compound is manifesting all the muscarinic and nicotinic symptoms, we should understand what is the structure of this acetylcholinesterase enzyme, because all the management of OP poisoning depends on this enzyme. So it is a 12-stranded mixed beta sheet surrounded by 14 alpha helices. It has got two important sites, which is anionic site and esteric site. In normal physiological condition, the acetylcholine molecule sits on both the anionic site as well as the esteric site, and it gets broken down by the acetylcholinesterase enzyme into acetic acid and choline in fraction of seconds. This acetylcholinesterase enzyme is seen predominantly in RBCs, plasma, as well as the synaptic cleft in the central nervous system and the peripheral nervous system. So coming to the organophosphorus compound, it sits only on the esteric site of the acetylcholinesterase enzyme, competing with the acetylcholine. So there occurs competition between the organophosphorus compound and the acetylcholine for the esteric site, but the anionic site is let free. We'll see the significance of how to utilize that anionic site in managing the patient. So once it sits on the esteric site, it forms a very strong complex. It starts inhibiting the enzyme. So the acetylcholine, which is released from the presynapse, doesn't get broken down by the acetylcholinesterase enzyme. It starts accumulating. That leads to excess of muscle depolarization, later followed by relaxation. So the muscle lands up in relaxed phase or hyperpolarized phase. So the patient develops severe muscle weakness, including respiratory muscle weakness, leading to the respiratory failure. So the organophosphorus compound, once it enters the body, it gets metabolized into some inactive metabolites, and majority sits on the acetylcholinesterase enzyme and starts inhibiting that enzyme, which is a reversible acetylcholinesterase inhibition. So whether this reversible inhibition will become irreversible or not, that depends entirely on what compound the patient has taken and how soon we give oxime to that patient, and and how long it's been since the patient has consumed the poison. So these are the compounds, commonly consumed compounds by the patients. There are 6 compounds here: parathion, paroxone, quinalphos. The A, B, C first 3 compounds are the ethyl compounds. The fourth D1 is the methyl compound, and the last 2 are the atypical compounds. They are profenophos and prothiophos. Among the ethyl compounds, parathion is the most common poison we encounter here. We hardly encounter methyl poisoning, methyl compounds, and we had encountered 3 to 4 cases of profenophos poisoning in AIIMS Bhopal. So what is the importance of these methyl, ethyl and atypical compounds? It decides the aging factor of the acetylcholinesterase enzyme. For example, the aging half-life of this methyl compound is around only 3 hours. So if a patient has consumed this methyl compound monocrotophos, and if at all he arrives to our emergency within 3 hours, then only the pralidoxime or whatever the oximes we are giving, acetylcholinesterase reactivators, that is going to help us. If the patient is coming to us after 12 hours or 15 hours, it is not going to help us, because by the time the patient reaches us, the acetylcholinesterase enzyme has already undergone aging and it is irreversibly inhibited by the organophosphate compound. If the patient has consumed ethyl compound, the half-life of that ethyl compounds are 33 hours. So we have a buffer period of 33 hours for us to give oximes in ethyl poisoning. If the patient has consumed these atypical compounds like profenophos and prothiophos, the half-life of these compounds are just 30 to 60 minutes. So if the patient is bringing a bottle of profenophos with a history of consumption of this compound 3 hours or 4 hours, then it's of no use giving oximes in this patient. It is not at all going to act, because by the time the patient reaches it is already undergone aging, and the organophosphorus has formed an irreversible inhibition over the acetylcholinesterase enzyme. So this is, I think, one of the most important slide in this presentation. We should know what compound patient has taken, so that we can expect the prognosis, we can expect how soon the recovery will be, and we can prognosticate the patients. So coming to the clinical features, rule of 3, based on symptoms and signs, can be divided into 3: muscarinic symptoms, nicotinic symptoms, and central nervous system symptoms. Based on the timing of consumption, timing of presentation of the poisoning, it can be divided into acute, delayed, and late. Acute is the patient presenting with muscarinic symptoms within 1 day. If the patient presents with symptoms after 1 day up to 2 weeks, it is delayed. If the patient is presenting with features of nicotinic symptoms or muscarinic symptoms after 2 weeks, it is late OP poisoning. Based on the organs, it can be classified into predominant cardiovascular manifestations, respiratory manifestations, or central nervous system and peripheral nervous system manifestations. So this is the rule of 3, dividing the clinical features based on the symptoms, timing, and organs. There are two more terms, which is DOP, delayed organophosphate encephalopathy. This encephalopathy usually occurs after 5 to 7 days of organophosphate consumption. We had got a patient who was totally fine on admission. On 2 to 3 doses of atropine, he got fine, but after 5 to 7 days, he started developing altered sensorium, followed by he lost his consciousness. We had to intubate him, and he typically mimicked like a brain dead patient. But we remained patient, and his reflexes started gaining after around 2.5 to 3 weeks, and after 4 weeks he got tracheostomized and got discharged. So DOP is one of the brain dead mimic characteristic feature in organophosphorus poisoning, which usually occurs after 1 week. And the fifth term is COPIND, which is chronic organophosphate-induced neuropsychiatric disorder, which is usually seen in farmers who gets exposed to very small amounts of organophosphorus for a very longer duration of time, maybe for months or years. They usually present with some extrapyramidal symptoms, tremors, anxiety, or some neuropsychiatric features. They usually do not present with muscarinic features, so it is very difficult to diagnose this chronic organophosphate scenario. So based on the symptoms, we are all aware what are the muscarinic symptoms on all the glands and organs. On the glands, it is a sludge, all the secretion, salivation, lacrimation, urination, defecation, vomiting, so diarrhea will be there. Organ-specific muscarinic symptoms will be severe bradycardia and hypotension, and meiosis followed by bronchoria and bronchospasm, leading to respiratory failure. What are the nicotinic features? Based on the central nervous system and peripheral nervous system and neuromuscular junction, it leads to severe neuromuscular palsy, fasciculations, and the classical intermediate syndrome because of the predominating nicotinic symptoms despite absence of muscarinic symptoms. So it usually occurs after 48 to 96 hours after the consumption of organophosphate poisoning, where the muscarinic symptoms usually subside and the nicotinic symptoms predominate. And what are the central nervous system features? There are 3 types of palsies that can occur in an organophosphate poisoning patient. Within 24 hours, usually type 1 palsy is seen, where respiratory muscle weakness can be seen. Patient can have anxiety, restlessness, and patient can through generalized seizures. After 24 hours till 2 weeks, the patient can develop type 2 palsy because of persisting nicotinic symptoms characterized by extrapyramidal symptoms, fasciculations, tremors, and proximal muscle weakness, ocular muscle weakness, neck muscle weakness, and respiratory muscle weakness. This type 2 palsy troubles us a lot in ICU patients because it becomes difficult for us to wean off them from the ventilator. Type 2 palsy is typically seen in intermediate syndrome patients. Type 3 palsy, which is usually seen after 2 weeks, which is predominated by neuropathic features where muscarinic symptoms are hardly seen. And again, here tremors, patient having altered sensorium, delirium, extrapyramidal symptoms, and fasciculations along with weakness. That again is going to extend the stay of the patient. So this is the nutshell of all the clinical features of the organophosphorus poisoning. These are the 5 terms we must know when when encountering an organophosphorus poisoning. The commonest clinical manifestation is acute cholinergic crisis, which occurs within 24 hours, where muscarinic symptoms usually predominate. What are the 4 symptoms the patient usually present to us is all the muscarinic symptoms, sludge, along with bradycardia, along with an altered sensorium, garlic smell, which is the typical smell of organophosphorus poisoning, and meiosis. And these are the 4-5 features which are commonly seen in acute cholinergic crisis patient, which occurs within 24 hours. Second term is the intermediate syndrome, which usually occurs 48 to 96 hours after the consumption, predominated by proximal muscle weakness, neck muscle weakness, shoulder weakness, and diaphragm palsy leading to respiratory failure. So the stay of a patient prolongs by at least 2 to 3 weeks. Third term is the opioid-induced delayed neuropathy, which is characterized by the distal weakness. It usually occurs after 2 weeks of consumption, characterized by paresthesias, tremors, anxiety, and can even lead to coma. Here, the fourth term is the DOPE, that is delayed organophosphate-induced encephalopathy, which also usually occurs after 5 to 7 days of the consumption. that usually presents with encephalopathy, mimicking like brain dead patient. Fifth term is the chronic opioid-induced delayed neuropathy. It is usually dominated by neuropathic or neuropsychiatric manifestations. Hardly muscarinic symptoms will be seen. So these are the muscarinic receptors we are aware of by M1 to M5. This is the classification of clinical manifestation based on the timing, acute, delayed, and late. We already discussed this. This is the commonest manifestation where the patient presents with all the muscarinic symptoms: bradycardia, meiosis. So what is the emergency team management on admission? First and foremost is the detailed history. What did he consume? When did he consume? And how much he has consumed? To look for the typical garlic smell of the patient. And even if we are doubtful about the history and the smell, then we can do an atropine test by giving 1 to 2 milligram of atropine and test for reversal of the cholinergic symptoms, whether it is occurring or not, and send RBC anticholinesterase, acetylcholinesterase level, if at all available and feasible. It is not a must because it is more of a clinical diagnosis rather than a laboratory diagnosis. So the triad of our management is ABC, atropine, and AIIMS. That's all in a nutshell. First is always A, B, and C. Whatever the case it is, whatever poison it is, first focus will be on ABC, airway, breathing, and circulation, along with the universal precaution, because if we touch the patient and if it gets contaminated, we can get diarrhea and vomiting. So universal precaution is a must. Immediately remove all the clothes from the patient's body, wash the patient with soap and water, and gastric lavage should be done only if the patient is awake. If the patient is semi-conscious or unconscious, do not do gastric lavage. Better to secure the airway, intubate the patient, take him on mechanical ventilation, and then do a gastric lavage. If at all patient reaches to us within 2 hours of consumption, then activated charcoal might have some role. If the patient comes later, then activated charcoal is not going to help us much. Most of the patients present to us with severe hypovolemia and electrolyte disturbances because of severe vomiting and diarrhea. So first step, this simultaneous correction of volume and electrolyte should be going on as a first step. So the first step is to put the patient in the lateral position, head down position, prevent aspiration. If the patient is semi-conscious or unconscious, immediately intubate the patient and then only do a gastric lavage. Otherwise, better not to attempt for the gastric lavage. Second most important step is giving atropine, which is the drug of choice for organophosphorus poisoning. The dose is 1 to 3 milligrams stat, followed by every 5 minutes. We can double the dose. Every 5 minutes it should be repeated until atropinization is achieved. We'll see what are the atropinization targets in the next slide. Third step is giving AIIMS, which is otherwise called the acetylcholinesterase reactivators. Though it has weak anticholinesterase activity, they help in reversing the acetylcholinesterase enzyme activity, thus neutralizing the organophosphate poisoning effects. So first is ABC. Immediately put the patient in the left lateral position and do an oral suction if at all patient is having secretions. And third step is the gastric lavage only if the patient is awake, and to avoid gastric lavage if the patient is semi-conscious or unconscious. Lateral positioning, oral suction, we should wash the whole body because it gets secreted in the skin even. We should avoid trials in a semi-conscious patient. We should get a gastric lavage done, and intubation should be on priority basis, and start bombarding atropine. So once we start giving atropine, our targets will be heart rate more than 80, systolic blood pressure more than 80, and clear chest, in the sense bronchuria should settle down, and all the sludge symptoms will be settling down. These are the 4 criteria mandated to say atropinization has achieved. One point which has been removed recently is the pinpoint pupil. The pupillary size normalization is not required to say atropinization is being achieved. One more confounder in achieving atropinization is tachycardia, because most of the patients are hypovolemic. That can cause tachycardia. In the initial phase, the patients are quite in a fear of dying, so the patients are anxious. That can cause tachycardia. If at all patient has aspirated, it can cause hypoxia leading to tachycardia. These are the 3 common confounders where the patient can present with tachycardia along with other muscarinic symptoms. So tachycardia should not be a contraindication for giving atropine, and it should not be the only criteria to decide whether to give atropine or not. And once the atropinization is achieved, 10 to 20% of that atropine dose should be given per hour infusion till 24 hours to 48 hours, and can extend it even up to 5 days. Always watch for the atropine toxicity, which includes fever, tachycardia, delirium, constipation, and urinary retention. If at all patient develops atropine toxicity, we can consider holding the atropine for a short duration of time, and in that period, if the patient has predominant muscarinic symptoms, we can consider glycopyrrolate. Even though glycopyrrolate is a tertiary compound which does not enter central nervous system and it cannot tackle the central nervous system effects, it can handle all the muscarinic symptoms in the peripheral nervous system. Dose is 7.5 milligram diluted in 100 to 200 ml NS, running in an infusion, and the dose should be titrated based on the symptoms. So the third part of the management is this acetylcholinesterase inhibitor reactivators. The commonest drug which we use is pralidoxime. Apart from this, obidoxime and trimidoxime or the other drugs available, but this pralidoxime is quite cheap and easily available. So coming to how does AIIMS act? This is the acetylcholinesterase enzyme. We all are aware that the organophosphate compound sits on the esteric side, so the anionic site is let free. So on giving AIIMS, this AIIMS starts binding to the anionic site, and it forms a strong bond with the phosphorus atom of the organophosphate compound. So this AIIMS organophosphate compound slowly starts dissipating from this acetylcholinesterase enzyme, and even the esteric site is set free. So now the acetylcholinesterase enzyme is ready to neutralize or hydrolyze the acetylcholine, so the muscarinic symptoms improves. Again, what are the common questions while giving AIIMS? Should I give? Yes, you should give. When should I? How much should I give? 30 milligram per kg over 20 to 30 minutes, first bolus dose, followed by 8 to 10 milligram per kg per hour infusion. If we consider a 60 kg meal, the bolus dose will be around 1.8 to 2 grams over 30 minutes, followed by 500 milligram per hour infusion. Up to 48 to 72 hours we can continue. Recent literature advises us to continue for 12 to 24 hours after the atropine has been stopped. So when should I give? Again, it depends what compound the patient has taken, whether it is a methyl, ethyl or an atypical compound. If it is an atypical compound, do not give AIIMS, it is not going to work. If it is a methyl compound, if the patient has reached to us within 3 or 4 hours, then we can give AIIMS, it might work. If it is an ethyl compound, we have got a buffer period of 33 hours of half-life for the enzyme to get aged. So in ethyl compounds, we must give. And coming to carbamide poisoning, which is a close mimicker of organophosphate poisoning, pralidoximes are not supposed to be given because carbamide binds both the esteric and the anionic site, unlike organophosphate poisoning, which binds only to the esteric side. So there is no site left on the acetylcholinesterase enzyme for the AIIMS to bind. So what happens in carbamide poisoning if we give AIIMS? The weak anticholinesterase activity of the AIIMS will predominate, and the muscle weakness will get worsen. So in carbamide poisoning, it is contraindicated. We should not be giving AIIMS. So when I should not give? In carbamide poisoning, or if the patient is coming after consuming profenophos, like atypical organophosphorus compounds. How long should I give? 48 to 72 hours, at least 12 to 24 hours after stopping atropine infusion. So these are the 4 compounds which we encounter commonly to decide whether to give AIIMS or not in the emergency department. So this is all about the management, starting from ABC, atropine, and AIIMS. So other tried and tested therapies which are still in vein, FFP, albumin, and lipid infusions, all these 3 were attempted and believed that it will bind to the organophosphate poisoning and that will get excreted to the kidney, but the evidence is very, very less and it is not advocated. Hemoperfusion, again, it was in 1 or 2 randomized control trials. Hemoperfusion has been tried in patients who came to emergency department within 4 to 6 hours of consumption. So it had shown certain benefits. Again, the evidence is less. And the role of antioxidants, clonidine, is very, very less. So it is not recommended. So these are the take-home bullet points: history of the compound, the timing, and the amount of the compound is very important. Second point is the garlic smell along with sludge symptoms with the bradycardia and myiasis. This is considered to be the tetrad of organophosphorus poisoning. So regarding the management, ABC stands first, followed by the atropine, which is the drug of choice, followed by the AIIMS. We should know when to give, how long to give, and when not to give. Thank you.